Record. It's on. All right, make sure. For those who are joining, I'm just going to mute a lot of you just to keep the background noise down, just so you know. Okay. Good afternoon on the East Coast. My name's Chris Knudsen. You're joining us for the December EMS Medicine Live conference. So now time for the holidays, and thank you for joining us so close to Christmas, but I appreciate it. Just to review, for those who haven't been here before, this is EMS Medicine Live. The idea being this is a resource for both academic and EMS physicians. I hope we can share information about good cases and things we've learned in our practice. And some points we do board review, not today, but board review as well. I think one of the benefits of having a webinar session is to get as many peers of ours to talk and discuss, have questions and discuss the topics either during the presentation or afterwards. Obviously, this is Zoom. I'm going to keep everyone muted for the conference, just as too much background noise. If you have a question, you can message EMS Medicine Live, which is my laptop next to me, and either I can have you interject during the presentation, or we'll save them for the end and just ask questions then. This is being recorded. You can record on your end if you'd like, but we're recording on our end, and we of course will publish this both on our website and on our Facebook page afterwards. If you want to find both those, just Google EMS Medicine Live. We're the top 2 results. At the end, we'll unmute everyone, and we'll have people ask questions. And yes, today, I'm actually kind of excited about today. We have Kevin Munjal from Mount Sinai. He did his EMS fellowship at New York City Fire Department, has his master's in public health. I had a hard time fitting all of his titles into the slide, so I kind of had to make it a little smaller. But now he's currently at Mount Sinai. He works for both emergency medicine and population health science and policy. He's the associate medical director of their pre-hospital care program. He works for, well, he's the founder of New York Mobile Integrated Healthcare for New York State, doing both policy and I guess policy and promotion of the topics to talk about today. He's grant funded, and he's the chair of NESP's national committee on these topics as well. He'll plug that at the very end, I know. But with that, I'll hand it over to Kevin.
Well, thank you so much for having me, Chris. This is a really great, it's a great forum that you've created here. And so I'm honored to be able to speak to everyone today. Just checking, you can hear me okay?
Yes, we can hear you fine. I'm going to turn off my video here 1 second, then I'll get you going. There you go.
All right. There it is. Okay. So he already kind of went over a lot of my credentials. I am funded by the NIH, as well as some funding from the Center for Medicare and Medicaid Innovation, a small piece of 2 different innovation awards. We have a couple of foundational awards, and a policy project funded by NHTSA and others. I'm having trouble advancing. Oh, I have to click. Got it. Okay. That's more or less the same thing. That's a disclaimer. So I'll talk about my Medicare funding. It doesn't reflect Medicare's position. Okay. So as most of you are quite well aware, EMS today is kind of focused on emergency care, focused on transportation. And unfortunately, I think despite recent movements in healthcare policy, we're still relatively detached from the rest of the healthcare system. We have a one-size-fits-all approach. You call 911, you get an ambulance, and basically ambulances take most patients to the ER. This is largely both informed by and perpetuated by EMS reimbursement policy, which very strongly ties payment to transportation. And so that has downstream costs, that has an effect on the way we do business and the way we might want to make change. It inhibits the ability to make changes. So you look at the consequences of downstream costs. So most of us in metropolitan areas and elsewhere build very expensive, elaborate 911 systems. We educate the public, we put public awareness, we're ready to respond. There's $0 in reimbursement for that. We have, sophisticated emergency medical dispatch systems. We're able to segment out calls, prioritize calls. There's a lot of medical decision-making behind there. And as of now, there's $0 in reimbursement. If you were to add further ability to segment out low acuity calls, send them to a nurse triage line, etc., there's $0 in reimbursement. Now, if you arrive on scene and you evaluate the home in addition to evaluating the patient, there's no way to capture the value for that today. It's $0 in reimbursement. Now you provide sophisticated care, and certainly in where I practice and probably in many of your jurisdictions, we're providing increasingly sophisticated levels of medical care, often able to stabilize the patient to the point where perhaps the ER may no longer be the most appropriate destination. But that treatment, with a few minor exceptions, it has $0 in reimbursement. But if you were to make that drive to the hospital, which in some metropolitan areas like my own might be a block or two, now you trigger both the EMS bill as well as the facility fee at the ER. And so you have a pretty impressive charge basically associated with that 2-block drive from in a very short distance. So no wonder, when you have this kind of model, we're contributing perhaps to the growth in total healthcare expenditures in the United States. And I think it didn't have to be this way, and it doesn't have to be this way. A lot of people smarter than I met about 20 years ago now, 1996, and published this report, the EMS Agenda for the Future. And the vision was that the EMS will be community-based health management that is fully integrated with the overall healthcare system. It will identify illness and injury risks. It will provide follow-up care, disease management, community health monitoring, and then will be integrated with other healthcare providers of public health. But we haven't quite achieved that vision, even today. And this wasn't just in 1996. This was kind of a lot of these ideas around, prevention came from the very earliest days in EMS. And it's no wonder that there were some programs that, looking back, were essentially community paramedicine programs, even as far back as the 1950s. And that continues to this day. In Alaska, a rural area, hard to reach patients, they have community health aides and practitioners, some of which overlap with the EMS role, providing a sophisticated amount of care. And it's been a very productive use of resources, of limited resources in their community. In the 1990s in New Mexico, prior to the EMS Agenda for the Future, there was a project in Nevada they called the Red River Project. And they trained providers. They definitely kind of gave them a little bit broader scope of practice. And there was some successes, some failures, but overall the program collapsed. One, because I think there probably wasn't enough.
Oops. Sorry, Kevin. Let me fix that.
One, probably because there wasn't enough oversight. And two, because the rest of the healthcare system wasn't ready for it. There wasn't necessarily a benefit to providing a new model of care when we were still in a fee-for-service model. The earliest mention of the word community paramedic is credited to this article in 2001, and credited to Kevin McGinnis, who many of you may know from the SEMSO. And he talked about, improving integration with the healthcare system, advanced training, collaborations between EMS agencies. And, again, we weren't ready for it. We were still in this fee-for-service model. And, we continued to do procedures and bring patients to the hospitals because admissions means money. Now, fast forward to the last 5, maybe 8 years, healthcare is changing. We're making this slow progression from a focus on volume of services provided to focus on value, and value translation means, what are the outcomes for that patient? We're no longer paying for each individual element of care. We're starting to bundle payments. And so where you are included in a bundle, suddenly there's an ability to move dollars around and try to focus on ways to lower cost and do more. The rest of the healthcare system is moving from a fragmented delivery system to a coordinated healthcare enterprise. People are talking to each other. They're moving data between each other. For the most part, unfortunately, EMS is still left out in the cold. And I think that's, for those that haven't sort of recognized that we need to sort of get more involved or more integrated, I think we really are missing the boat, because the dollars for just transportation are shrinking, and the dollars for population health management and coordinated care are rising. So I think we need to figure out which side of that boat we want to be on. We're moving care more and more out of the hospitals and into the community. This is a quote from the CEO at Mount Sinai Hospital. And Mount Sinai has spent the last, I think, 100 years of its history being the best at fee-for-service medicine. I mean, we do all kinds of fancy procedures. We have transplants, all kinds of special capabilities. And for a hospital like Mount Sinai to suddenly change gears and start trying to do population health management, I think really shows that there's, the tide has turned, and we need to all figure out in EMS how we're going to be a part of this new system. So he said the hospital tomorrow will be judged more by its ability to maintain a community's health as opposed to filling its beds. And EMS, of course, is in the community, and so hopefully we are well positioned to support that role. Again, EMS, we're out there, we're on the street corner, right next to that patient that the big data people are recognizing as the frequent utilizer, or is the one with their glucose out of control. And if we're there and we have the ability and capability and interest, we can be a valuable part of the healthcare team. So what is mobile integrated healthcare and community paramedicine? So this is a little bit of a moving target, but I try to be as up to date as I can. So the latest draft version of the joint vision statement on mobile integrated healthcare and community paramedicine describes it as the provision of healthcare using patient-centered mobile resources in the environment. Short and sweet. It then goes on to try to clarify the difference between CP and MIH. Before I get to that, I'll just add the NIMA sort of addendum to that. That's the New York Mobile Integrated Healthcare Association's, our addendum to that definition, in that it should be performed in a coordinated manner with physicians, hospitals, and other providers, and encompasses a myriad of potential expanded roles of EMTs, paramedics, and the EMS systems to provide higher quality patient-centered care and help prevent emergencies before they begin. So what's the difference between these two words? Well, the latest definition tries to elaborate that community paramedicine is the provision of services under the direction of an EMS agency, and mobile integrated healthcare is the provision of services coordinated by some entity that may not be an EMS agency, in which EMS is an integrated part of that delivery system. So those of us that are sort of in the conversation trying to come to, as best as possible, an agreement as what these terms mean, have not yet agreed on a visual diagram to kind of best explain, where the overlap is and where it isn't. But here is my best effort, which is a little bit of a spectrum between community paramedicine and mobile integrated healthcare. It includes a lot of the same services, but ultimately the definition differs more based on who is directing the service and what's the degree of integration and collaboration with other healthcare services. So there are probably many ways to sort of group MIH-CP programs into buckets, and our organization in New York has come up with the following buckets that we think are helpful. So one is patient-centered emergency response, the second is integration with healthcare services, and the third is integration with public health. So let's look at each of these individually. So patient-centered emergency response, this is what we've all come to describe and know as, you know, the alternative destination discussion, whether we can do treat and release, whether we can do treat and transport to alternative destinations, whether we can do nurse advice lines. I think all of those things, the way to provide 911 care in some other manner than a one-size-fits-all approach, falls into this bucket. So we know that not every patient that calls 911 is a life-threatening emergency. The range of estimates is as low as 7%, as high as 61% meet the criteria for low acuity. But what we don't talk about as much is that there are a huge number of patients, and increasing each year as we have more population health efforts, that are already plugged in to other healthcare services. So in my system, that is not a scientifically valid circle in terms of its size, but approximately 48% of my patients that arrive on a Mount Sinai ambulance to Mount Sinai Hospital, turns out they're affiliated with a practice that has 24-hour on-call services that are intended to avoid the use of 911 and avoid the use of bringing patients to the ER. So clearly, these are the same patients. Our patients are their patients, and so we need to figure out ways to connect the dots. So I'm sure many of you are familiar with the discussion and controversy as to, you know, whether or not, actually, before I get to that, this data basically supports the idea that at least some proportion of patients, perhaps as high as 68%, are supportive of alternative transportation modalities. Up to 69% are supportive of or accepting of going to an alternative destination. And there's a variety of other data points that were asked about, but certainly some proportion of patients might be agreeable to some of these new models of care. This is some research that we've done here at Mount Sinai, showing similar high levels of support and even preference for some of these alternative destination models among ED patients. So the federal government is not blind to this. In fact, they cited this article in this still draft, for some reason still a draft white paper from the three federal agencies that make up FICOMS. It's entitled Innovation Opportunities for Emergency Medical Services, and the entire paper basically talks about, well, if we use the number of 15% of Medicare ED transports are treatable outside the ED, and we do some math, well, it turns out that perhaps as much as $600 million could be saved per year for Medicare patients if we were to create flexible payment models that paid for non-transports. So some people are trying this. In fact, Medicare actually helped fund Reno, Nevada's REMSA, their innovation project. They have three components, but one of them is taking patients to alternative destinations. There is newer data available, and for those of you that will attend the NAEMSP pre-conference on MAHCP, Brenda Staffen, the lead director for this program, will be presenting her data as well as some lessons learned in San Diego in about a month's time. But here's some early data. It looks like they saved $2 million in charges by transporting 550 patients to alternative destinations. I believe that was in the first 1.5 years. Wake County has an alternative destination program as well, and they have a couple of different protocols that they've been nice enough to publicize. One of which is for mental health and substance abuse patients, using some exclusion criteria, they were able to redirect about over 200 patients in a year, and a huge reduction in ED bed hours and EMS unit utilization. I'm sure they're working on their financial analysis as we speak. As you know, there's a controversy as to whether or not EMS, and particularly paramedics and certainly EMTs, have the ability to figure out which patients can be safely transported to an alternative destination. This has probably been the major stumbling block for the development or the proliferation of alternative destination models in the United States. So this meta-analysis published in 2009 came to about a 91% negative predictive value for paramedic determination and medical necessity. And they do have some secondary endpoints. They were a little better at whether or not the patient needed admission and stuff like that. And so this has been cited as the reason why, we can't accept missing 9% of patients that should be seeing the ED. So, if you look at some of the studies, there's two studies, Pointer and Haynes. If you talk to, President-elect Brent Myers of NAMSP, he'll argue that it's really only those two articles and probably only the Pointer article that really did a good job and had valid endpoints. And so the accuracy was quite high. If you talk to others, ultimately the issue is, well, how do we do this safely? And in these underlying studies, some of them had protocols, some of them had just paramedic impression, and maybe there's evidence-based ways to make this number safer. And then yet a third argument is, well, urgent care centers have approximately a 6% rate of which they transport patients, they refer patients to the ED. So how good is good enough? And so one option is to do science, right, and use the evidence. And so, again, going back to Wake County, they did a retrospective review and came up with a protocol that had very high levels of sensitivity and specificity. The quick analysis on it would have saved $2.5 million per year in just one county and would have avoided transport 70% of the time using this protocol for low-risk falls or minor falls in assisted living facilities. Another model is to do what they're doing in Houston, which is to have, from the field, call a physician and use telemedicine or some other means to try to safely determine which patients are appropriate to go to an alternative destination. I believe in that model, they're even able to, the physicians are even able to provide, treatment recommendations and help them with appointments and things. And they do follow-up calls. Sometimes they do taxi vouchers, etc. So not everything has to be about alternative destinations. You can innovate within the 911 system and do great things for your patients without necessarily trying to triage low acuity calls elsewhere. A great partnership is between EMS and hospice, and MedStar is probably one of the first to successfully pilot this. They pre-register hospice patients in their community with the EMS agency. So when there's a call from that location or they arrive and they have that patient, they recognize that that's the patient who the call is for, they dispatch, in addition to the regular response, they have a community paramedic response, and they also send an immediate alert to the hospice nurse so they can choose to either respond in person or to communicate by phone with the rest of the team. And they have some additional protocols to comfort the patient. And overall, I think it's been quite successful. I know that one of the leaders of the MedStar, the local hospice agency, I think Vitus, actually has moved to New York and is begging us in New York to try to get our act together and work with them. And hospice is actually paying EMS for every patient they enroll. They pay some fee to EMS to pre-register the patient and have them be prepared to do this type of response. So that's really a great model to look for. Again, besides changing the, having your EMTs or paramedics transport to alternative destinations, another part of the modality is to try to use either nurse or other types of helplines and transfer calls directly from 911 to this other call center, or publicize a non-emergency phone number, so some kind of an alternative for the patient who knows they don't really need 911, but they're not sure how to get their questions answered or how to triage themselves. And so this has been very successful in Reno. As you see at the bottom there, they estimated savings of $4.3 million, and that was about a year and a half in. So that was all part of the first bucket of programs. The second bucket is integration with healthcare delivery systems, or ACOs. Excuse me. Integration with healthcare delivery systems, this might include a variety of different things. It might mean your population data people are recognizing which patients they want to target in the communities, or maybe the EMS data is looking at the same frequent flyers we always look at, and now there's just dollars behind it because the ACO or some other population health group suddenly has the dollars to spend in a proactive fashion to try to manage these patients. What we're doing here at Mount Sinai, which we think is a nice way to integrate with the healthcare system, is we know that EMS brings patients to the hospital in the 911 system, but we also transport patients home from the hospital. Both ends of this are part of the care transitions business. We recognize that patients when they leave the hospital are confused about next steps, and elderly patients have a high rate of falls. So we built a program that works with this transport and adds value. So we call it Transport Plus. So we do a discharge comprehension assessment, try to make sure they're aware of what the basic instructions are. And we try to do a home fall risk assessment, trying to look for very easily assess and high yield minor falls in the home. Our data is pretty good. Patients seem relatively pleased with the overall intervention. 83% of the discharge comprehension was helpful. We found deficiencies in over 20% of the patients in terms of their knowledge of their discharge instructions. And there were even cases when the discharge forms were incomplete. We had to call back the hospital and try to get questions answered to help avoid a patient from either being non-compliant or being unable to follow a plan. We found a whole bunch of fall hazards, probably about at least 2 in every home. And at 1 month follow-up, 90% found it helpful, and 45% reported making a change to the home environments based on EMS recommendations. That was duplicate, okay. And then another program that sort of has to do with transitions of care is, again, going back to Texas, MedStar has a CHF readmission reduction program where they do frequent visits, I think approximately twice a week for about the 30 days, 4 weeks. They check vital signs, weight, med compliance, edema. They communicate regularly with the primary doctor and cardiologist. They're able to do point of care testing. They give additional Lasix or other diuretics. They have a very well-developed protocol, but a lot of the care is done sort of in real time or otherwise consulting the specialist, making them aware of the patient's condition. And they're saving about $700 per patient that they enroll in this program. Western Pennsylvania has a safe landing program. Instead of, as we do it in New York with the actual EMT who's driving you home, do the program, they actually do a follow-up visit in 1 to 2 days, or they do several home visits after discharge with a paramedic. They do a medication reconciliation, develop a system response plan, and make sure they get to their follow-up appointment. And they also recorded quite impressive savings, 1.2 million hospital charges. The third sort of bucket of these programs, integration with the public health infrastructure. This might mean giving vaccines, doing fall hazard assessments as we were doing. Maybe a great idea we haven't developed yet in New York, but you're free to steal this one. Maybe collaborate with me, is to do a personal preparedness training, especially for vulnerable patients, so we don't have to fly them out with a helicopter the first time there's a hurricane or something. And also, of course, syndromic surveillance is huge. A lot of places have trouble doing immunizations. Pennsylvania is a nice example of a workaround where they actually, instead of looking at the EMS law, they looked at the Medical Practice Act and recognized that the physicians in the state were allowed to delegate their authority to other individuals. And so they got the Board of Medicine to authorize EMTs as technicians under that act. And therefore, they do it as an extension of the physicians. So in addition to 3 buckets of programs, there's also 3 potential settings in which you might want to innovate in your program. So one is trying to innovate within 911. Another is to try to work with your either interfacility or non-911 units, or you may be in a system where units move back and forth and that's less of an issue. But then it is often a different issue to do scheduled or non-emergent care. In fact, some states, including my own, expressly prohibit EMS to provide care in non-emergent settings. So one way to provide care within 911 is to try to, create better connections, on the scene. So if you're a patient that a paramedic responds to a patient, perhaps instead of automatically transporting or providing care in a vacuum, perhaps they can better integrate with the healthcare system by communicating from the field with the specialist or the primary doctor or some other system command center type of position at the hospital and try to improve the care that's provided. Maybe outside of 911, you might want to this is a program that we're doing at Mount Sinai, in which our primary doctors are able to request a paramedic response outside the 911 system. So, if you think about EMS as emergencies, I think you're missing the boat. What EMS does is provides unscheduled care most of the time. So a patient has a new medical complaint, they might, we like to generally think that, okay, or policy people think that, okay, they're just going to figure out where they need to go and they're always going to get it right. But the reality is it can be quite confusing. They're not sure where to go. And while these nurse advice lines might be a great idea, most people will first try to call their doctor if they haven't been jaded from the fact that the doctor never picks up usually. But, we have a couple of practices here where the physicians always answer their calls, and they get back to their patients, and they do a great job trying to keep them out of the hospital. But even for those physicians that we work with here, sometimes they're not able to manage the new complaints. So their traditional choices are, try to manage it over the phone, take 2 of these and call me in the morning sort of thing, or to refer the patients to the hospital. And for elderly patients, that usually means use an ambulance. But we introduced the third option, which is some version of a community paramedic or mobile integrated healthcare response. And so basically we go back to the same picture, but this time it's at the physician's request. We're dispatching EMS to the home, and they're evaluating the patient using their paramedic skills. They're using telemedicine, but even just a telephone is fine to communicate back with the same doctor that was on call in the first place and was trying to manage that patient over the phone. So now they have the benefit of eyes on the scene, vital signs, perhaps EKG or other types of diagnostic testing, and they're able to walk the paramedic through additional physical exam and other types of evaluations in order to get a better sense of what needs to be done and hopefully keep that patient out of the hospital. We've done about 25 of those responses since October in our program here. And we actually had to create a new level of certification in our city. So approved by our regional EMS council, we created a new title called the telemedicine physician, which is a sub-certification of online medical control. So instead of going through all the things that an ER doc has gone through to be certified to provide OLMC, these primary doctors are authorized to do telemedicine with their own patients by going through an abbreviated course. So the third bucket is sort of that scheduled care, non-emergency care. And this is probably what I would say the majority of people associate with the phrase community paramedicine. Programs that go after frequent flyers, that do proactive home visits, try to help the patient navigate the system. MedStar, they were able to reach out to a handful of patients and dramatically reduce ED bed hours and came up with a very high number of potential savings. Reno also has a community health paramedic. Again, they're trying to do home safety and injury prevention. They're doing in-home services outside of an emergency call to do, try to improve adherence to the plan, make sure they know which meds to take, improve their health literacy. And so they're also, they're reporting a very impressive readmission reduction rate from 18 to 13%. And they've been doing it for a little while now. So Minnesota, which many of you may know, is home to the national curriculum on community paramedicine. Their model is primarily to take providers, give them a lot of extra training, house them within primary doctorate offices or affiliate them with primary care practices, and they do home visits for high-risk medical patients. And they also work with nursing homes and assisted living facilities in the state. Mesa, Arizona, I believe, is also doing some work in this area. I don't have a lot of details about their program just yet. And I give a shout out to a program in my state that shows that even with a relatively small amount of money, less than 100,000 for EMS agencies, we're able to start a pretty impressive program. They do proactive home visits. They do newborn safety kits, concussion awareness for youth sports. There's an idea. They do fall prevention and elder check programs. So shout out to those folks in Mark Spezio from my state. So, we talked about these three settings, and I want to help you understand where this fits into the grand scheme of things in healthcare. So I think everyone in the, that's trying to reduce costs in healthcare looks to avoiding the ER visit as an opportunity for savings. Now, as ER physicians, you may or may not agree. You may very much adhere to ACEP's line about the 2% of costs are part of the emergency medicine. That generally ignores the inpatient costs associated with our admission decisions, and often the cost of the ER visit are subtracted when the patient gets admitted, so it doesn't even count in our data. All that being said, so we have this is sort of the cascade of events. You have a patient who's stable in chronic disease, so a population health management program might try to make sure they're enrolled in a patient-centered medical home, so they have access to services, and try to keep on top of them. When they recognize that patient having an elevated hemoglobin A1C or somehow otherwise being uncontrolled in their disease, they're going to reach out to them. They might assign a disease case manager or try to give them improved access to additional services. When despite that, a patient might develop an acute exacerbation, in which case, hopefully the patient already has a symptom management plan taped to their fridge. But if not, then they want to give them access to nurse advice lines and other types of resources to try to make sure they can triage themselves appropriately and avoid going to the ER unnecessarily. However, some amount of patients slip through all those cracks and they do self-triage and they might end up in the ER. And many people see the fact that if they do call an ambulance, again, that's a failure, and that's a failure of their prevention efforts, and that patient's going to end up in the ER. Well, innovating within the 911 system means trying to change that model and recognize that we can provide patient-centered out-of-hospital care. Maybe we can do treat and release. Maybe we can at least do treat and coordination and with the rest of the healthcare system. That's innovating within 911. But what about the other settings? So perhaps outside of 911, maybe we can intervene a little bit upstream. Maybe when they did call the doctor or the nurse advice line, maybe that patient could get an ambulance response or a paramedic response or an EMT response or a telemedicine technician or a nurse or some other piece of the healthcare system to visit that patient urgently and try to figure out ways to intervene. Even more upstream, of course, is the community paramedicine sort of preventative home visit, looking at, again, the frequent flyers, the patients that just discharged from the hospital, trying to figure out ways to prevent them from coming in. So these are some of the ways in which EMS potentially can interact with everything else that's going on in healthcare. So if there's any slide that you burn in your brain, I think this is the one. So I have to thank Matt Savatsky for sharing some data from NAEMT's national survey on MIH and community paramedicine practices. I just want to bring you up to speed on what's going on in the country. So there was a lot of responses. They identified 232 unique MIH CP programs in the country. And another 15% indicated that their agencies were in the process of developing a program. So some of the programs that are out there: frequent EMS, frequent users, post-admission, readmission reduction teams, things that extend the primary care model, treat and release or treat and refer programs, and 911 nurse triage were some of the more common programs out there. So who's participating? So most of the people on this call, I believe, are EMS physicians. So just so you're acutely aware, the medical director, the physician needs to be involved in these programs. If not, in fact, the person driving the program from the outset, they need to make sure they're not in the way and they're being an advocate for the program, and they're helping liaise between EMS and the rest of the healthcare system. And it's not always just paramedics. In fact, a lot of programs use EMTs or mid-levels to participate in these programs. Sometimes they're paid more, sometimes they're not. For the most agree that there is no advanced scope of practice required. Again, from NSEMSO did a survey as well, and a couple of tidbits from theirs. Are agencies required to have medical directors specifically for that activity? Over 50% of the states responded yes. And I'm sure the others will probably move in that direction. And is online medical direction commonly available for CPMH activities? And most states reported it yes, but that's probably just reporting on what the programs are doing themselves. So I'm sure as physicians you want to know, well, what's the data? Is any of this working? Well, here's some international data. So from England, community paramedics were able to reduce the likelihood of ER visit within the next 4 weeks by 28%. They increased patient satisfaction by 16%, and no adverse effect on mortality. So that was a sort of a proactive home visit program for the elderly. Another program in which they were doing falls prevention saw a 40% reduction in falls among patients not transported and referred by EMS to community falls prevention groups. Interestingly, that's more or less within the 911 system, or as they call it, the 999 system. And they would basically evaluate a patient on scene, and then if the patient was relatively benign, they would actually refer that patient to a community falls prevention group. And the third, looking at cost effectiveness, showed, and I think this is very important for everyone on the phone, it increased costs in the pre-hospital system, but lowered costs per quality by a pretty significant amount of money. So this is huge. So the fact that EMS right now is often siloed by itself and is paid for transports in this country means that we have a lot of trouble getting over this hump. We would actually have to increase the amount of expenditure in the pre-hospital system in order to effectively do a lot of these programs. And the benefit to society is significant, but there has to be a way for there to be a transfer of funds from elsewhere in the system where it's being spent and it's a cost to the EMS where it potentially could yield savings. And figuring out how to navigate that is perhaps the biggest challenge. So here's a 2013 systematic review of community paramedicine programs, and I encourage you to read this paper. It goes into depth on each of the underlying 11 papers, but if you can kind of make out faintly in the right-hand column, looks like 10 of the 11 were favorable or showed cost effectiveness towards community paramedicine. Only one showed no significant difference. So there is some data out there to support, but again, you have to be willing to rely on international data. There is American data, but a lot of it is sort of as I showed you in terms of the earlier in the examples of programs, looking at potential cost savings and reduction in readmission rates, which are not necessarily sort of the standards that are used in some of the international studies. So, obviously we need more research. There was a national agenda for community paramedicine research written in 2012, which cited gaps in looking at effectiveness, looking at the values to society, patient safety, improving access to care, and it outlined, almost outlined research questions in those 10 or 11 topic areas. So if you are a EMS fellow or even a medical director looking to embark on a little bit of a research career, I think this is a decent document worth perusing that at least gives you an idea of where the needs are. And there aren't a whole lot of studies since then that are missing. So some considerations for community paramedicine, can we do that? So there's a document that came out of the Association of State and Territorial Healthcare Organizations, or something like that, that looks at what are the strategies by which you can accomplish certain CP and MIH programs in states. Believe it or not, nothing in this document recommends changing statute. It just describes which ways and which strategies you might be able to have valid authorization for a program in your state. So a very useful tool to look at. More on the statutory side, on the SEMSA, one of the questions they asked their state offices, have you interpreted your EMS statute as allowing community paramedicine in the state? And so about 50% believe that it does. About 28.57% thinks it's expressly prohibited. A handful didn't have any interpretation. So, it depends on which state you're in, obviously, but potentially there are some things that are legal. For those of you that are from New York, our state has recently determined that alternative destinations are in fact legal and require no regulatory waiver. So now the power lies within our regional EMS councils and our state EMS council to authorize. But community paramedicine, non-emergent care, providing any kind of medical intervention on a scheduled basis is considered prohibited by the law. So another consideration is EMTALA. If you're in California in particular, you'll face a lot of resistance from fellow emergency medicine physicians who are advocating strongly for positions like this one that state that every patient that calls 911 needs to have an EMTALA screen exam at the hospital by an ER physician. So, I've heard from experts on both sides of this. I'm not sure where it totally stands, but it seems like the consensus, or a bit of consensus, seems to be that if you're a hospital-owned ambulance, then EMTALA does apply to you. If you're not a hospital-owned, then perhaps EMTALA does not apply to you. But I'm not sure where that's going to land. Another really important consideration if you're thinking about developing a program is what kind of model you want to go for. This is an operational question. Do you want to go for a dedicated model, which is probably the more prevalent model that you hear about in some of the more outspoken programs? They take a few providers, they give them a lot of extra training. The Minnesota curriculum is about 300 hours. They are not available for traditional EMS while they're on community paramedicine. They do often have more autonomy, and their scope, while many will say it's not expanded, is relatively broad compared to the systems approach, which is a model in which you make many, or in fact all of your paramedics or all of your EMTs part of the program. You give them minimal extra training. Think of it as an in-service on a new protocol or a protocol update. They are still available for traditional EMS, and it's within that context that they may get dispatched to a call that falls into a new protocol in which you might be doing alternative destinations, treat and release, or you might be doing some kind of special communication with the primary doctor or something of that nature. They usually have less autonomy and very narrow protocol-specific scope of practice. Another consideration is what educational model. This is obviously informed by the previous slide, where if you took a few providers, you might want to give them a lot of extra training. But if you're trying to train your whole system, then you probably won't have the ability to train everybody for 300 hours. So can you do something that's more geared to the specific program or innovation that you're looking to pursue? Another question is, another consideration, of course, is, especially for this call, is for you as medical directors, what's your role? To be an advocate for the program, you may need to have an interest in public health or primary care or get some more education. You should assist in program development. You should develop guidelines and protocols to direct the care of patients. There's always a lot of, well, what if this or what if that happens? And you need to come up with answers that are reasonable and viable. Design policies and procedures to involve other specialists. This is huge. So you probably don't want the primary doctor in the community or the cardiologist in the community sort of independently provide medical direction to your medics without your involvement. So you need to figure out a way to involve them, but somehow maintain, your level of, appropriate level of oversight over the whole system. The curriculum we kind of mentioned, and then of course data. And you need to collect data. You need to be measuring, useful metrics to evaluate the success of your program. You need to perform continuous quality improvement. Probably need to do case reviews, and then figure out how you're going to provide continuing medical education, because everyone's skills degrade, even community paramedics. So here's some of the measures we use in my program, and actually we're not able to do all of these as yet, but this is our dream list of data for our community paramedicine urgent response program that I mentioned earlier. There is, so a better tool than looking at this is actually, there is a template, which I didn't include here, but there's a community paramedicine measures group that has come up with about 17 draft measures for the scheduled home care type of intervention. They call it the community health intervention. And that is available, I believe, on the NAEMT website. That's a useful place to look for some draft tools, and others are being developed. That you might get some ideas for metrics from this tool developed by HRSA in 2012. And you do need to move data, and this is just some information from a research study we did, that patients are generally surprised that we don't already have access to their medical history or are sharing data with their primary doctor, but they're pretty comfortable if we did. Definitely do not underestimate the challenge of overcoming culture. Many a good idea has failed in EMS because it didn't get provider buy-in or other stakeholders. Here's some other places to look for more information. Again, the NAEMT Resource Center. There's also a monthly call on community paramedicine on the third Monday of every month, organized by NSEMSO, and they call it the Community Paramedicine Insights Forum. And I'd like to encourage you to visit our website, the New York Mobile Integrated Healthcare Association, NYMA.org, or nycommunityparamedicine.org. And our website is updated almost daily with new information. And if you're not from New York, if you look at the Around the Nation page, you can look up stuff in your state, or articles or programs that are going on nearby. And a quick plug for the Promoting Innovation EMS project. This is that policy project that we're working on. We're looking to overcome barriers at the local level. If you go to emsinnovations.org, you can get updates on that program, and we will also be presenting at NAEMSP. The goal is another document, perhaps, if we do really well, it'll be might be considered as useful or as timely as the EMS Agenda for the Future was 20 years ago. And we're looking to provide a framework for communities to figure out ways that they can be more innovative with EMS. And then finally, this is the pre-conference, the Wednesday of the meeting in San Diego. We have speakers like Brent Myers from Wake County, Brenda Staffen from Reno, Mike Wilcox from Minnesota, who helped develop the national curriculum, and many, many more. So please consider coming to that. And I think that's it. And I know I went a little over, but hopefully we have time for some questions.
Oops, start video. Yep. So I'll start off with a question before I unmute the group. So every time I look at this, there's obviously cost savings. When you look at these models, they project money saved by not transferring folks, taking care of them in the home, and gone to my hospital, some of these ideas. And the answer is the amount of pain that they get from readmissions is less than the amount of money they make from readmissions. Granted, it's going to change in the future, but they're not that interested in taking part. So I guess the question is there sustainability amongst any of these mobile integrated healthcare programs or community paramedic programs where they're not being funded by hospitals or not being funded by grants, or they're working and they're making it financially balanced?
Yeah, I mean, I would look to perhaps MedStar in Fort Worth, Texas. I don't believe there's ever been a grant they've received.
Okay.
And they're getting paid from the hospice agency, from the hospitals for the CHF program. They get paid by the hospitals for observation avoidance program, in which when you as the ER doc feel uncomfortable discharging a patient, you're able to say, you know what, I'll discharge you, but I'll make sure a community paramedic visits you once or twice so I can avoid using a bed overnight in the hospital. The hospital actually pays them for that too. So if you're creative and a good negotiator, perhaps we can, you can be successful. I think the grants are a good place to get started, but also don't underestimate the ability to internally fund these programs. And that may seem like a far cry for some folks, but chances are you're not actually getting reimbursed for a lot of the work you're doing. So if you can direct your interventions towards those non-reimbursed charges, often the frequent flyers, etc., it might just be moving costs, and that might be the basis for you to start a pretty valid and impressive program.
Fair enough. Okay. Other question, Alternative Destinations in New York State, when did that come out? I totally missed that.
Yeah, so I did try to send it out on the NYMA newsletters, but as part of, so our state, like many of your states, has enrolled in a 1115 waiver program. So basically the state applies with their Medicaid program to Medicare and asks, we'd like to spend our dollars differently. So it's usually called DSRIP, Delivery System Reform Incentive Payment Program or something like that.
Right.
And so as in preparation for the DSRIP programs, as guidance to all the agencies that are looking to do things that they knew were perhaps on the edge of what was currently allowed, they provided a very large document with guidance. And in that, they addressed two issues for EMS. One is community paramedicine, which they didn't really define, but just said it wasn't allowed. And then they said alternative destinations, which they said there's nothing prohibiting this, so no waiver is required. A very blanket, wording that says it's legal. So the power for alternative destination, or the opportunity for alternative destinations, is alive and well in New York State. But now I know in my REMAC, and I'm pretty sure at the CMAC, there's plenty of things on the books that sort of define it as going to the hospital. So it's up to us to come up with, appropriate methodology to unravel some of that regulation.
Okay, fair enough. Thank you. I'm gonna unmute everyone else, so don't. Anyone else have any questions at all for Kevin or us or anyone else? I'm gonna go once. All right. Cool. I think that's it. Kevin, thank you so much for presenting. I think this is one of the best topics, or a hot topic right now in our field, and certainly learn more listening to you every time. So I appreciate it. Thank you so much. I do want to remind folks we have next year's schedule almost filled out. January and February are still open. I think I'll be doing January, topic to be determined. If you want to volunteer for a different topic, let us know. I think next year looks a little bit different than this year. We now have folks from across the country, from the Southwest, the West Coast, Southeast, all taking part in this, so we should get some different points of view. I appreciate all the New York folks and Northeast practices that have been working with us, but I'm looking forward to getting folks from across the country next year. With that, I think we're all done, and thank you so much.
Thank you so much.